you very much. Glad I made it up on the stage here. Almost fell. It would have been an even grander entrance. First, let me recognize and acknowledge, first of all, the organizers of this event. The energy here is enormous. There are two Aminas that have warmed the room through song and verse and eloquence, and have managed to melt Tony's or FDR's ice of indifference. And so I'm coming in at the end to try and provide a few more remarks to add to what I think has been a sensational opening to this meeting. First, let me begin by congratulating Norad on its results report 2013 on health and education. Like Tony, I'm limited in my Norwegian, but I did manage to get through the 12 key findings in the executive summary, and I have to say they resonate. Education for all is critical. The equity dimensions, the quality, higher education, are all critical dimensions of that agenda that we need to put more attention to moving forward. Likewise, the importance of global collective action to achieve our results, and then innovation for better health in particular, but I would also say for better education. But what I particularly liked about what I read in the executive summary was what I attribute as the spirit of learning, both from success and failure. And I think the only failure in development is the failure to learn from failure. And I think this is something in the context of results and value for money we sometimes discount. But some of our greatest learnings are from where we fall short. And therefore we need not to hide, but to recognize and learn from failure. I'm going to make two sets of remarks, one in the area of health, where I know a little bit, and the other in one area of education where I feel competent to make comments, and that's with respect to higher education, particularly as it relates to health, and that relates to my former employment as a dean of a school of public health at Brak University in Bangladesh. However, with respect to health, let me begin. We're living in very exciting times in health. We're into the last 750 days with respect to achievement of the MDGs. MDGs 4 and 6 are very much on track, and I think we should look at that and feel a huge amount of success. MDG 5, with respect to maternal and reproductive health, is not quite so much on track. But if we look across the landscape, we see a lot of acceleration and reason for optimism, although concern for some residual areas where we need to pay more attention. And finally, on MDG 1, with respect to nutrition, again, a mixed picture where we really need to keep our eye on the ball with respect to childhood nutrition. We've just had the release earlier this year of the high-level panel report, and their health is very much part of the development agenda post-2015, a focus on continuing to achieve what we need to achieve with respect to the MDGs, embracing the NCDs, the non-communicable challenges, which are very much part of the development context now in every country, and finally, understanding how we can move health systems more comprehensively towards coverage for all through universal health coverage. And then finally, just last week in London, we had the release of the Commission on Investing in Health report through the Lancet. And here, there's some very interesting results that I think bear sharing in this meeting. First is that $1 invested in health, according to Larry Summers, one of the chair of the commission, gives between a $9 and $20 return on investment. And he was saying, as somebody who spends his time dealing in financial circles, that this makes health a very attractive and competitive area for investment relative to all sorts of other things one could invest in. So there is, again, without going into the details of how that figure is arrived at, good, strong, or stronger evidence that we have a very positive return on investment. Secondly, the report talked about a grand convergence around 2035, and I think this is extremely exciting. And this is the idea that levels of maternal and child mortality can decline across all countries to the same levels that are seen in middle-income countries at this point in time. And that's a massive leveler with respect to life chances for mothers and children, and very much within reach. And finally, the report articulated a set of pathways to universal health coverage that recognize the importance of providing financial risk protection in health, avoiding impoverishment due to payment for health care, and secondly, increasing access to essential services. So these three things, I think, make it a very exciting time. Last week in Japan at a meeting on universal health coverage, our President Jim Kim articulated time-bound targets for universal health coverage, in which he said, we aim to cut in half by 2020 the numbers of people impoverished by paying for health care, and by 2030, eliminate impoverishment due to health care expenditure. And for service delivery, he articulated the goal of doubling coverage from its current 40% level of essential service amongst the poorest to 80% by 2030. So if we're going to achieve these ambitious targets, we need to think about the short and long term. And I think three things are particularly important. First, we do have to continue to recognize that we need more money for health. And this involves increasing and sustaining public expenditure for health and doing it in ways which is pooled, progressive, and prepaid. And secondly, we have to keep our eye on the private sector. If the private sector isn't part of the solution, it may well be part of the problem. Pay-as-you-go systems are regressive, exclusive, and inequitable. They do not have a role as a primary form of financing in any healthcare system. In addition to more money for health, we need more health for the money. And here we need to really harvest the bounty of insights and innovations that have been derived through the implementation efforts over the last 15 years to scale up essential interventions. We have a huge knowledge that's been achieved through having the ambitious target of putting 3 million people on treatment for HIV by 2005. We have a huge amount of knowledge acquired through the Global Alliance on Vaccines and Immunization in trying to achieve 80% immunization coverage for all children in the world. And likewise, through a very enlightened investment by the government of Norway and the United Kingdom in 2007 in a Health Results Innovation Trust Fund, we now have a huge experience on how results can be achieved more efficiently with quality to achieve important outcomes over 30 countries. And this results-based financing now is really changing the way we think about investing, not only at the World Bank, but also amongst other partners. Let me give you just one example of a very recent study undertaken in Argentina called Plan Nacer. This program enrolled poor women in health insurance. It provided incentives to providers for comprehensive preventive and treatment services for those women. And the impact suggests the following: a 32% reduction in stillbirths, a 23% reduction in low birth weight babies, and a 74% reduction in neonatal mortality. Now, half of that reduction in neonatal mortality is thought to be due to the preventive services provided through antenatal care. So here's a pathfinder. We know that the residual child mortality agenda requires us to really get to grips with neonatal mortality. And here in Argentina, over the last 5 years, using a results-based financing approach, we have insights on how we might make progress on that, a very important front. Finally, it's not just doing what we can do in the health sector. We really need to think about mobilizing other critical sectors to secure the foundations for healthy societies. And this means looking at agriculture and food so that we get the right nutrition in the first 1,000 days, looking at fiscal policy so that we get taxation right to reduce tobacco consumption, looking at transport so that we have road safety, looking at social protection so that conditional cash transfers can put money in the hands of poor women for health and education. And finally, looking at education and recognizing that health and education share this virtuous cycle of promoting one another. Better health leads to better education, and better education leads to better health. So let me segue now and talk a little bit about health. And I want to caveat my comments, first of all, by saying I'm not the representative for education at the World Bank. We do have a director in charge of education with an Education for All mission. We have a global partnership for education, which is well known, which is housed at the World Bank. They're doing very good work. They will continue to do that, and I think share many of the comments that have been mentioned earlier. Let me focus on higher education, particularly as it relates to health. And I do this putting on my former hat as a dean of a school of public health in Bangladesh, which was called, or is called, the James P. Grant School of Public Health. I'm looking at Tony Lake because James P. Grant was the executive director of UNICEF, and Jim Grant really dared to think, I would argue ahead of his time, that it was really possible to immunize the world's children. And in the 1980s, he led the expanded program of immunization, and really that vision that every child in the world should have access to immunization as well as other essential interventions. The school was born in the spirit of Jim Grant, and I had the great opportunity to be its dean in the last 3 years. But when we think about higher education and health, let me first say, point to some areas for concern. And I think these are not specific to health and higher education, but they may be. First relates to issues of quantity and quality. We're not getting the right numbers of students. We don't have the right numbers of faculty. We don't have the right quality of educational outcomes. We don't have the right quality of teaching. Diversity and distribution. Our students and schools are principally located in urban areas. They cater primarily to those wealthier children who have had opportunities and have little concern for the health problems of the countries and that they're located in. One positive thing that we've seen in diversity is that in higher education for health is that there's been a feminization, an increasing participation of women, particularly in medical education throughout the world. And then finally, issues related to institutional innovation and the sense that in many countries, there isn't an active strategy or policy to guide higher education with respect to health professional education. Rather, it's a laggard. And what we see is, by default, growth, new entry of private sector efforts, but with little sense of how they're contributing to the larger whole. So what are 3 opportunities to improve higher education and health? The first, I think, is to draw on a concept that was provided by a commission on higher education for health professionals in the 21st century. And in that commission, of which I was a member, they identified 3 levels of learning. The first level of learning is well known. It's informative learning, and that's the factual base of learning. Less known but equally important is the formative learning, and that is really the values. Ethics, equity, fair distribution, those are essential to training health professionals, and I would argue many other forms of professionals. But the last form of learning, I think, is perhaps the most important, and the one that we shouldn't overlook when it comes to education, and that's transformative. And that means people are not there simply as robots to perform functions. They're there to lead and make change. They are change agents. They're the ones that are going to improve the performance of institutions. So the transformative learning is particularly important in the context of higher education in the 21st century. Second, I think we need to think about our models of education in the context that institutions of higher education are fundamental for knowledge generation, translation, and reproduction with respect to the challenges that society faces. And what we tried to do in Bangladesh is develop a praxis model of education inspired by Freire's pedagogy of the oppressed, but really with a view to bringing knowledge to be in the service of solving critical problems in health. And that problem focus allowed us to identify 4 critical domains of knowledge. One is to understand how to describe problems. 2, how to develop solutions for those problems. 3, how to deliver those solutions. And 4, how to know whether if you've delivered those solutions, you're actually having the intended effect that you expect. Finally, I think we need to think about more innovative institutional models. We were faced in Bangladesh with the challenge of scaling up midwifery training. There were no formally trained midwives in the country, and the Prime Minister of Bangladesh committed to 3,000 midwives being trained by 2015. We developed something called a hub and spoke model for training community midwives, in which we used the umbrella of a university and identified 8 outposts for training women who were selected from their communities to serve in their communities and were trained in their communities as midwives. When thinking about this sort of model, the obvious question that comes into play is, does it make sense? And here I think is a further challenge for higher education as it relates to health. What are the criteria for evaluating whether or not it works? And here we were pushed by one of the funders of our community midwifery program in Bangladesh to answer those questions because our funder was interested in value for money. And so we developed metrics on what it cost per year of education for a midwife. We developed metrics on effectiveness, which is what are the number of lives saved over a career of work of a midwife properly trained. And we developed a return on investment criteria, which was what was the monetary return to an investment in training of midwives. And on all of those fronts, we were surprised to find much better results or outcomes or metrics than one might have expected. The cost of training a midwife in terms of the return on investment was $1 to between $6 and $16 to the economy as a whole. And this was derived entirely by preventing unnecessary C-sections, cesarean sections. So a partial analysis suggested that there are very rich and important returns to education. And in that regard, I think this is an area where we're pursuing this at the World Bank, but I think we need to invest much more seriously at looking at what are the returns to higher education and health, but I would argue beyond to not only health, but higher education in and of itself. Let me conclude then by saying 3 things. First, Health and education are essential goals of development, important ends in and of themselves. They are also central to achieving the overall development goals of eliminating extreme poverty and boosting shared prosperity. We know that more investment in health is a very smart economic investment. Education is very likely as good or better, but we need better evidence. And perhaps one of the things we need to think about moving forward is an analog to the Commission on Investing in Health called the Commission on Investing in Education. Education 2035, the analog of Global Health 2035, may illuminate all sorts of opportunities for strengthening our investments in education. And finally, I think we need to commit to time-bound targets and use results-based financing to source, share, and scale innovations in delivery in both health and education. Let me conclude by congratulating Norad on being at the vanguard of this moment of this movement, and we look forward to your further leadership. Thank you very much.